And we're on page 172. Yes, don't stick that whole thermometer in there. We want to make sure you separate the buttocks, 1/2 to 1 inch. And also number 12, underline that. Hold on to the thermometer at all times. You do not let that thermometer go. Your body is naturally going to try to expel that thermometer just because it don't belong there. It's just, and that's the place for it. Because if it goes in, it's your body says, okay, we got to get it out. So it's actually just going to work its way out. And so make sure you hold on to your thermometer because it will come right on out. And number 14, gently remove the thermometer. Wipe the tissue or remove the sheet. Most of the time we're going to be able to remove the sheet. And make sure you warn them. That's my tip of the day. Make sure you warn them. I had a young lady. She had diarrhea, and you shouldn't be taking or rectal temperature on that. But she had stopped having diarrhea, and they gave her medicine for it, and she hadn't had it. Anyways, they thought it was safe. I forget what was going on. We couldn't take a normal one. They wanted at rectal temperature, and when I pulled the thermometer out, right behind it came some more diarrhea, and it probably started her back. You know, it's something that happens when you do that, but it probably something happened back there. But yeah, that messed me up. So warn them. And I've had that situation almost exactly later, and I just told the lady, I said, okay, hold on. And you kind of, because they naturally, it's something you kind of hold on. And then when you pull out, all that stuff is not coming behind it. So you got to make sure that, warn them. I'm just warning y'all. But let them know before you just take it out. But it has to be there at 3 minutes as well. So underline it. For the tympanic membrane, that next page, right over where it says measuring and recording your tympanic, that is the little machine that you put to the ear. It's not going to go in the ear, but 1/4 to 1/2 inch. It's not really going to, you're not going to put it in there too much just because you really can't, because the way it's shaped. But that's only 1/4 to 1/2 inch into the ear. But what I want you to know is number 7. Position the resident's head so that the ear is in front of you. Straighten the ear canal and gently pulling up and back. So that's what I want y'all to write or underline. Up and back. Pull up and back. And that's going to get your most accurate temperature. Anytime you're doing a tympanic temperature, we want it up and back on the edge of the ear. And we're still going to do that like if you're putting drops in your ear, same kind of thing. And if you ever notice, when you pull up and back, it kind of goes down a little further. That's going to get your most accurate temperature reading as well. So up and back. Flip on. For your axillary temperature, make sure that you know number 8 and 9. Position the thermometer, which is of course the bulb end, or you know if it's electric, the probe. In the center of the armpit, fold the resident's arm over. It says him chest, but over his chest. Over his chest. Because that's actually going to give you the temperature you need. And hold it there as well. But this is the catch. Look at number 9. How long are we going to have to leave it there?
8 to 10 minutes.
Forever. 8 to 10 minutes. But we love the ones that beep. How long? That could be, 30 seconds. But it gradually gets to the correct temperature. That's just the problem here on your axillary. So 8 to 10 minutes on the axillary temperature. Long time. For your pulse, what's this pulse called?
Is it the
Radial. Apical. You wrote apical. The apex of the heart.
Yeah.
This is your radial pulse. This is the one that we're going to check when we're checking pulses.
I was trying to find out. I couldn't find out.
Yeah, you was okay. Yeah, I seen you put, but it's just pulse. But what's our number need to be? Our pulse?
Needs to be between 60 to 80.
60 to 80. That's your pulse. And this is your radial pulse. What is this one called? We'll use this for blood pressure, and that's my hint. Starts with a B. Brachial.
Oh, sorry.
This is your brachial. Have y'all been feeling y'all's brachial pulses? see if you can find yours. Should be, you got your middle of your arm and you go to the side a little bit. It's more pinky up. If you follow your pinky, come on up. It's gonna be the inside of your elbow. You feel it?
I still can't feel my shirt.
You gotta come on over a little bit. Come on over. There you go. Press in a little bit. Press on.
Okay.
And that's how you have to do, depending on your person. Some are just sitting on top of your skin. Mine is on top of your skin. Some folks, they got a hard one. Some folks, you gotta press a little bit in. But it's beating just like ours is. It's just a little deeper. It's in there. So that's how we're gonna find our blood pressure. So y'all make sure y'all go fill in on other people's, because we're gonna do some blood pressure too. So get on that. And actually, in the nursing home, I'm gonna try to pull y'all away and do some blood pressures one-on-one, because I want to make sure you don't leave out of here, because it may be one of your state skills, and I want to make sure that you know how to do it. So make sure you're looking at your videos. Don't go past those videos. That's what y'all need to be focused on. We're learning this. I'm not gonna have your test on this. We're gonna do this. And I just lied. We're still gonna have to take the test. But I want y'all to do your skills. Do your skills. Focus on that. All those other questions, y'all probably just rang off the top of your head. Hopefully, and we'll go over the test so you'll know whether it is ringing off the top of your head or not. But skills is what I want y'all to focus on. Respirations, what's our number?
15 to 20.
Inspiration is breathing in, expiration is breathing out. And here in our book, they say 12 to 20. It just depends on where you're learning. 12 to 20, 16 to 20 is fine. We're not going to worry about it until it's under 12 a lot of times, because there's certain medications that we can't give if it's under 12. So that's why 12 to 20. So make sure that as well. Underline also, infants is 30 to 40. They just kind of throw that in there. Infants, 30 to 40. Flip on over our pulse. That's where we're checking it. And we're going to do that for a minute. Hello, my name is Cheryl Davis. I'm going to check your pulse today. Or I'm your CNA, and I'm going to check your pulse today. And we're going to start counting on the 12. And you count for that full minute. That is your state skills test. You got to make sure that you do that as well. Blood pressures, we'll actually do that. The top number is called your systolic. That is your working number. That's your higher number. And it sounds like a working number as opposed to diastolic, dying down. So know the difference between your systolic and diastolic. And what is the name of that thing sitting up there with the little gauge stuck to it? We call that the manual. When they say, let me have a manual blood pressure, that's the manual. And what do we call that machine or that apparatus? That big old word. Sphygmomanometer.
It's a what?
The cuff and the little gauge is called your sphygmomanometer. Sphygmomanometer. Okay? And that's what they call it. So if somebody be funny,
That's the same as.
they're gonna be funny and tell you to go get a sphygmomanometer.
That's the same as a regular blood pressure cuff, it's just bigger.
No, it is the same.
Oh, machine?
No, we're not talking about the machine. We're talking about the blood pressure cuff itself.
Oh.
And the little gauge that's attached to it. We're talking about the manual one. They call that the sphygmomanometer. The other one they call the, blood pressure machine. But when they say sphygmomanometer, that is what we call the blood pressure cuff. And with the little gauge attached. It's not bigger. Some are bigger. Some are littler. But we're still going to say, can you go get the sphygmomanometer on purpose? They're going to do that just to see if you know what you're talking about. But that is the blood pressure cuff itself. We actually call the other one the blood pressure machine. And you'll see most of the time it's blood pressures, your top systolic, diastolic, pulse, O2 set. You'll always have to count respirations. That's no matter what, no matter where you're at. It's easy if you put your hand on their chest or on their side, and breathe with them. Always breathe with them to get that best thing. Do not take a blood pressure on that page 177. Blood pressure should not be measured on an arm that has an IV a dialysis shunt, or any medical equipment. Anything going on with that arm, avoid that arm. If it has a cast, a recent trauma, paralysis from a stroke, any burns, breast surgery. That's the one you're really going to watch out for. And they'll tell you most of the time, but if somebody's unconscious or asleep or whatever, just don't be sticking it on there. Make sure somewhere that, especially breast surgery patients, they'll probably have a note on the wall somewhere that says not left arm, or not right arm, or no arms. It'll tell you. It really depends, because they don't want, because that blood pressure actually squishes this, and it has something to do with what goes on with the lymph nodes and glands that happens right here, so it can mess them up. So we're not going to mess with mastectomies, breast surgeries, things like that. They're going to check somewhere else. Blood pressure we're going to actually do. So that is a wonderful thing. They have a picture of the pulse oximeter. Know that name, but that's what it's doing. It's checking your pulse at oxygen concentration is what it's doing. And that number should be anywhere from 95 to 100. Pain management, you see them little faces there? They call them the Walker Bond faces. And they've actually called pain another one of your vital signs now. So it's very important. We try to go with what the patient says. Depending on where you're working at, they have different theories. But most of the time, we're going to go with what your pain says. If you say, and you just had surgery, you say your pain is whatever, we're going. Now, if you just walked into the ER yesterday and last week and before, and steady asking for pain meds, we might think that you're seeking. But also, I want to be that person. Don't just keep sending me and giving me pain meds. Yeah, I just told you I have a problem. I need you to fix the problem. I'm gonna have pain until you fix the problem. Don't give me pain meds. I want pain meds, thank you. But fix what's causing the pain, and then I won't come see you no more. Fix what's causing the pain, and that's the whole thing. Don't let them just send you out with pain meds. They ain't done nothing. You've not fixed nothing. What's my problem? Can they get fixed? And then pain medicine is good. Know that there are several barriers to us nurses trying to give some pain meds, and one of them is like older people thinking that arthritic pain and all that pain that they go through is normal. It's not normal. That is not what we should be going through. We don't want pain. That is not a normal sign of aging. So a lot of times we can't treat that because of that, and they call that a barrier. A barrier to managing pain is the feeling that someone thinks that pain is normal. And they're going to word that in your test, and that's the wordage. Read that question real good. A barrier to managing pain is the feeling that someone thinks that pain is normal. And that is a barrier. We can't manage it if you think it's normal. So look that one up when you see it. Height and weight, same as we did in school. You just measure them and make sure you know that 12 inches is in a foot, and you'll be fine. For weights, we can weigh a patient in a wheelchair. We just weigh the wheelchair by itself, either before or after. But we need to know how much a wheelchair weighs. And then we can weigh the patient and the wheelchair. If they can't walk, that's how we're going to weigh it. Sometimes you have to weigh them, and you see that picture 726 in a bed. Archibald's got a little bed. You just push a little button. I don't know how accurate it is, but you just push a little button, and it tells you how much you weigh, which is kind of awesome. So you don't have to weigh that patient. But same for your height, we're still doing that. How are you going to measure a patient who can't stand up? We got to measure them in the bed. So we're going to measure from the top of their head to the bottom of their feet. And we measure in the bed, the up and down of the bed. We don't measure their breasts or legs or thighs or stomach, or we get a whole nother measurement. We're going to measure, we're going to write, or however you do it. And we're going to measure from here to there on the bed, not on the patient. That's not going to get you your correct height. So we're going to measure just like we measure if someone's standing up. We don't measure everything. We measure just the distance from top to bottom. And same for if they're in the bed. Also, they want you to learn about restraints. Restraints is anything that's holding that patient in. Even that bed rail is restraints. It's meaning I can't get out on that side. It's considered a restraint. A lot of nursing homes and facilities are trying to avoid putting them bed rails up for that purpose. A lot of times a doctor's order has to be ordered to keep those bed rails up. If it's a danger to them, they will keep them up. Also, that geriatric chair, they used to always sit them in, and this is why patients would go in a hospital, they go get fixed. Next thing you know, they'd send them to the nursing home and sit them in a wheelchair or sit them in a geriatric chair and put that little table. It's supposed to be for eating only, but they'd leave it there. And those people would sit there. Next thing you know, they don't get back up from there because they've been sitting forever. And then they couldn't walk any longer. So that is now considered a restraint as well. Anything that's holding that patient back from doing anything is a restraint. So they want them walking around. They want them doing what they can. They also want us watching them 24/7. If they say they're in a wheelchair, you can't put the seatbelt on. You got to let them be free. So if there's somebody who just don't understand they can't walk, we just got to look at them harder. We got to observe them more, not block them in. Also know that restraints, remember back in the days when I think of restraints and how bad restraints were, that's why another reason they quit doing restraints is because I go to the most extreme. Remember the one that they do this to? And they got your hands and everything locked like that. Imagine you're asthmatic. They don't know. You just was trying to fight somebody and they strapped you down. Imagine you have an asthma attack or you already can't breathe. And then what's going to happen? Nobody's around. They already just left you somewhere because you've been fighting everybody. And they just strapped you down, and that's what was happening. People were dying. People were getting strapped to the bed, and they weren't checking them, and they were getting circulation problems. And so they try their best not to put someone in restraints. Even our mental health patients, don't put them in restraints. And if we have to put them in restraints, they must have been hurting somebody or themselves, and we can only actually get like a 2-hour order and then renew it. And then actually every 15 minutes you got to let them move a body part because of circulation issues. So, and then after your order is up, you're like, okay, are you going to act okay? Are you going to be okay? You're not going to hurt yourself or anybody else? Yeah. And you give them a chance. Undo them. They start doing it again, we got to wrestle them back down to strap them back down. But that is the order. Sometimes they'll continue, but it's got to be, most of the time it's because they still cussing and fussing and acting a fool. When they calm down, you're supposed to let them go because they're calm now. So that's the whole point. We just keep them through their madness, through their episode, and then let them go. So that is where your mental health is right now, because we're trying to head for restraint-free care, and they're using restraint alternatives. Again, just anything that you can do that you won't have to put them in restraints. For our wandering people who like to wander, they put little ankle monitors on them. You know, if they hit the door, you know, alarms go off, all the doors close. Those are restraints, but they are actually restraint-free, calling them alternatives. We're not holding them back, but you know, if that's what they do, if they are the wanderers, we don't want to find them down the road. They'll even at the nursing home that you're going to go to. When a patient, there's a couple of patients, they get close to that door locks. You can't get out. You like, and then you look around and you be like, oh, there's a patient over there, and that's why that door is locked. So just make sure.
Their doors don't stay locked?
No, at 8 o'clock they're unlocked. Because some patients can actually go out and sit on the porch. They go out and walk. It really depends on the patient. But those wanderers, they're gonna lock.
But we still have the ankle bands and all that. Like I can get out of the door with my badge if they're closed. It won't unlock for them.
Because if that patient is there, you're like, look, if you don't go sit down somewhere.
It's the ones in there right now. And then you gotta go back that way.
You know, they gonna try to go out with you. I had one little fella, and I love him to death. He had like, I said, you are not, everybody in burgundy scrubs, and he's a little short fella. He's trying to get out with the students. I said, and that's one reason they got those locks on that door for him. And he was trying. See, he's not about to slip out. And so he was really trying to slip out, and I didn't see him in the beginning. little short fella, he was in there. And, so some of them I had to, I just had to tell the others, y'all stop. We had to shut the door, and we had to go out another door, because he was aiming to get out that door. But, because we already had the door open, it's not gonna lock, it's not gonna slam on us. Yeah, and that's a little trick too, they know that. He was a little fast. Anytime someone is in restraints, you gotta offer them something to drink, let them move their extremities, try to take them out of the restraints. Normally we can't keep them in there, but 15 minutes, and it has to be with a doctor's order. That's the most important part that we need to know as CNAs. It has to be a doctor's order. A nurse can say, doctor ordered, and then we can put it on. But it has to be a doctor's order. Fluid balance and explain I's and O's. We kind of touched on this, maybe. I can't remember, but what your magic numbers is, I need y'all to know. 1 ounce equals 30 milliliters. Just like this over here. You're gonna have to record this for breakfast, lunch, and dinner. How much they got intake. And if you're in a hospital, especially cardiac patients, all day long, anything that they're drinking, you're gonna have to record how much they're drinking in milliliters or cc's. Milliliters and cc's are the same. So if I got this soda, 20 ounces. So 20 ounces times 30 equals how many cc's? Right. So you're gonna record 600 if they drink the whole thing. You'll get to know, like this glass maybe looks like some of your nursing home glasses. Maybe it's 6 or 8 ounces in here. So six times 30 or 8 times 30. How I used to, you're gonna learn, because I would always be like, I look on the bottom. A lot of your cups and drinks or something would say 6 ounces. Or ask the kitchen staff, what's in here? Is it 6 or 8? Because the cups are either 6 or 8 most of the time. Can't go on up, but 6 or 8. Milk cartons. And I grew up with milk cartons, so I know what a milk carton is. But that milk carton is also a cup. 1 cup is 240 milliliters, which is also 8 ounces. Put all that together and you'll be fine. And that milk carton, 240. That milk carton is 8 ounces. 8 times 30 is 240. And that's also a cup. So those are your magic numbers. So any ounce you get hold to, if it's a 10 ounce, you can figure out the milliliters. 10 times 30, 300. And you just keep going like that. And each meal, you'll get so used to, when you do it, breakfast, lunch, and dinner, you'll get to where you can know your numbers. I know what I gave her. I gave her a 6 ounce, so that's what I gave her. But breakfast, lunch, and dinner, you're gonna have to record those I's and O's. Sometimes it may be out of catheter. Most of the time, your catheter is gonna have a little line that tells you that's 300 milliliters, or it may be in ounces, but they're still gonna want them in milliliters. If it says 6 ounces, 8 ounces, we're gonna have to figure out what the milliliters is. But what I want you to know is that first paragraph there. To maintain health, the body must take in a certain amount of fluid each day. Fluid comes in the form of liquids that a person drinks, also found in semi-liquids such as gelatin, soup, ice cream, pudding, yogurt. Generally, a healthy person needs how much? That's your most important part, and that's 64 ounces. And that's to stay healthy, keep your body clean, keep all your functions functioning. So we need 64 ounces of fluid a day. So we try. And
So do we have to record the gelatin, the soup and stuff as liquid?
Mm-hmm. Gelatin, soup, clear soups.
Yeah.
Anything liquidy is gonna be considered their fluids. And look at your, that's another question for your facility, how they're gonna do it. Are they gonna count that? And if it's fluids, it's fluids. Gelatin turns into fluids. Milkshakes turn into fluids. Anything in room temperature turns into a fluid is a fluid. Excuse me. That's a fluid.
So we definitely do secondary.
Yes. Gosh, excuse me. And you know, intake means intake, output means output. So fluid balance, all that means is what you take in, you also put out. That is a balance. So it has to be in balance. So if I drink 600, whatever that was, 600 milliliters, what do I need to be putting out? 600. That is called fluid balance. That your body's done what it's done, use what it's used. Sometimes it doesn't work like that. But that's why we do eyes and nose, especially for our cardiac patients, because if they're holding fluids, we will know. We're going to know not only through that, but also weighing them and doing their eyes and nose. Okay. And that is a sheet of eyes and nose. Most of the time it's done each shift. You measure everything. Every time you give somebody, this might be on their door or on their vital sign machine hanging. If you give them something, you record that. And then actually you give it to them, and then as you pick it up, you record it. You would put that and add it up shift for shift. And that's what that next conversion is, that first one. If y'all can get that in your head, you'll have a good life. Okay? And that last one. 1 cup, 8 ounces, 240 milliliters. And we'll actually do that with the urine. We'll practice that as well. Sometimes we have to collect a specimen. Sometimes it's a routine specimen. A routine urine is one they give you a cup and tell you to urinate. They'll also do a clean catch urine, which is on the next page, page 188. Clean catch just means that you got to wipe first. We're going to clean catch. The first part of the urine goes into the toilet or somewhere, into the toilet, and then the middle part of the urine is what we want for a clean catch specimen, or midstream. They call it clean catch or midstream. And it's because they're trying to find the correct amount of bacteria that's growing, or the real, because in the beginning you got sediments that go out, then at the end you got sediments. So in the middle they're going to see exactly what's really going on with your urine, and that's why they want a midstream. The first of the urine goes in the toilet, the last of the urine goes in the toilet. We just want the middle. That's why clean catch or midstream. Know those two. Know that those are simultaneous, same thing. Stool specimen, come on over. What I want you to know is page 190, number 12. Using 2 tongue blades, take about 2 tablespoons of stool and put it in the container. 2 tablespoons of feces is what you'll need. Make sure that you label that container and put it in a biohazard bag. 190, number 12. And you put it in a biohazard bag that looks just like this, and you put your specimen bag in here, or specimen in here. Make sure it's closed, labeled, and then you're going to have a requisition form that goes on the outside of this. Sometimes you won't have to do a requisition form, maybe the nurse will, but you'll have to collect it and bring it to them. And then they'll have to do all the stuff. Hopefully it's already labeled, or you might have to label it, make sure it's coming from whatever patient it's coming from. Also, come on down to the end of page 190, that first column. Early morning is the best time to collect sputum. We're talking about collecting specimens. So sputum, early morning. And that's when you can cough up the best out your lung. You've been laying down. And you cough, 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 and that sputum is what we want. We don't want that little spit. That is not sputum. Sputum is when we cough, get that good stuff out your lungs before you actually swallow it, because that happens automatically all day long. But it settled down a little bit as you sleep. So that first is when we want that sputum specimen. Same thing, you're gonna put it in the little specimen cup, just like the urine cup, same cups. Put it in here. Okay. Explain care guidelines for your urinary catheters. We would not be putting in catheters, but we might have to clean the catheters, and we actually do that skill as well. But you need to know what a straight catheter is as opposed to indwelling. Straight, don't even confuse it, straight in and straight out. Indwelling, it means it lives there. If you are indwelling or dwelling somewhere, that means you live. So put those two together in your head, you can't forget it. Straight catheter goes in and out, indwelling is dwelling, it lives there. And we will have to measure. We won't be doing the straight cast, so most of the time your nurses will actually have to measure that. Those other catheters we might have to do. And then come on down up under there, there's such thing as a condom catheter. They call it Texas catheter. All that is, it looks like a condom. It's the same thing, but it's over the penis and not in the urethra. It's over it. And I don't know why sometimes they choose one as opposed to the other. Probably the guys sitting there fussing. But if they can use a condom catheter, they will, if they can. But what you need to know about that condom catheter is the attachment is fastened with special tape. Underline that. And most of the time, your catheters are attached to their thigh. And you want to make sure that those stay straight and not tangled up in covers or not squished or all of the above when you're taking care of your patient. But that tape is actually an elastic tape, just in case it swells or unswells, so that it just don't fall off the patient. And that's just for your condom catheter. Know the difference in your straight catheter, straight in and out, indwelling lives there. Then you got your condom catheter, which is your Texas catheter. Also know that the indwelling catheter, the other name for that, and it's right beside it, it's Foley catheter. You'll hear Foley catheter a whole lot more. They got a Foley catheter, or they just got a Foley.
Yeah, I was gonna say.
That's all they're saying. They got a Foley, and that is your catheter. Always observe and report any dark blood in your urine or dark urine, foul smelling urine. Anytime it's in the wrong place, odor, all the above. When we are doing catheter care, what's the magic number we're going to keep the water at, even though we're just messing with catheters? 105. Don't forget that. We actually do that skill as well. Our most thing, you're trying to keep them covered for privacy. Otherwise, you're just cleaning. You hold it and you clean it. Hold it right at the meatus, which is right at the top with the urethra meatus, right there. And 1, 2, 3. You just clean it. Flip each time. And because it is a infection control thing, because same thing as you wiping somebody from that hole out. Then you flip it, 2, flip it, 3. But you might have to do, that's an easy. Let's go, we can do, okay. And they're showing you how to empty a urinary drainage bag. You pretty much just have to fill them out. Some are open different ways. Most of them got this little contraption that just kind of holds and folds. But you just got to pick one and figure it out. What you do is see how it works. The other ones are very similar. It just depends on who makes them. But most of them are very, very similar to how they fold to not let it leak. And it's got a little stopper as well. And really depends on who makes it. For oxygen therapy, middle of that paragraph there, up under oxygen therapy, nurse and assistants never stop, adjust, or administer oxygen. Nurse and assistants never stop, adjust, or administer oxygen. We will check, make sure that the nasal cannula is on there. We will check, make sure that it's not causing any skin breakdown. It'll cause skin breakdown on cheeks and behind their ears. So always make sure we're going to reposition them. If it's aggravating them, try to move them. But that's plastic on top of your skin, so it can just irritate. And so make sure that we're watching out for that as well. They might have a mask. Again, maybe you'll have to take it off after the medication is done, but you won't be placing them. But you might have to take it off after it's done. Make sure we're watching out for oxygen for combustion, because oxygen is very flammable. We don't want nobody smoking around it or electrical equipment around it. Just keep all that kind of stuff away from your oxygen tanks. And I don't want to go nowhere. So none of that. No fires. And if it is a fire that goes on, a lot of times they got a little oxygen thing they can turn off. Hopefully the whole building won't blow up. Possible though, with all the oxygen around. IV therapies, again, nurses, CNAs will not mess with the IVs, but we will report and tell the nurse if it's something wrong with it. We'll have to clean around it, but we won't be messing with it. Underline that's that last part, right above observe and report for IV therapy. Nurse assistants never insert or remove IV lines. They're not responsible for care of the IV site. Their only responsibility for IV care is to report and document any observation of changes or problems. Just make sure you report if something's going on with it. Otherwise, the nurse is responsibility for those IV lines. Sometimes it'll beep on you, especially in a hospital. They're always beeping. And it's just because somebody's laying on it or they have crooked it up some kind of way. And if you can just undo that, sometimes the beep will go away. Otherwise, not a lot of messing with the tubing or the lines. But most of the time it's because they're laying on it. And we can fix that. So make sure you report any of that good stuff that's going on with them. Discuss the residence unit and related care. All that they're saying is what's in that unit. And if anybody's walked into a nursing home or a hospital room, they all got the same kind of stuff in there. And y'all can read that there, but everybody's got the same stuff. And even I tried to do that room back there just like that. You should have that. They just won't have all the supplies on the side of their room. But their room's just as simple as a bed and bedside table, privacy curtain, and the things they'll need. Of course, we'll be watching, make sure, keep your rooms clean, junk, all that stuff we gonna clean up. Page 196, what's the temperature need to be in their rooms? And they can have it as cold or as hot as they want it, but what we're gonna set? Between 71 and 81, underline that. 81's pretty hot. And they will have it at 81. And they can turn it up a little harder, but you just have to go in there. That's their house. Don't be messing with their temperatures. That's their room. That's their house. And you just got to go in there and deal with it. And hopefully it's not a whole lot that you got to deal with. But especially older people, they do not like cold rooms. And yes, you'll see it. Also, that next G right up under that. Make sure there's no crumbs in their bed when you're changing them. Make sure you none of that's happening. But underline that last sentence. Change linens if they become wet, soiled, or wrinkled. And I just be like, wrinkled? They might become wrinkled kind of easy, but guess what? Change linens if they become wet, soiled, or wrinkled. So how often do you change bed linens? This sentence right there.
Whatever it means.
When they become wet, soiled, or wrinkled. Now, if they don't become wet, soiled, or wrinkled, every 2 days would be fine. That's when they became wet, soiled, or wrinkled. But it really depends on where you're at when it's mandatory. But test question: wet, soiled, or wrinkled. Okay. Make sure they're getting their proper sleep, and that's all they're saying. Y'all know how you feel when you're not getting your sleep, and how it can make you. And how we're going to help them sleep, and you would ask that. Sleeping too much during the day can cause bad sleep issues. Eating or drinking items with caffeine in the day can mess you up at night. Man, and you especially, you sitting there giving them sodas, and you expect them to go to sleep at night. You might as well just find them some water or some Kool-Aid or something else they can drink. They try to get them off their caffeine. Coffee they love. They still loving coffee. Wake up in the morning for coffee. Yes, they loving their coffee, but let them get their coffee in the morning. That's gonna boost them up, get them a little energy, get them moving, but not throughout the day. That you can't do. Wearing night clothes during the day. Make sure they got their night clothes. You want to put them day clothes on during the day, and come nighttime, you put on night clothes. You bathe them, put them in clothes on, just put you to bed. Just like you would anybody. It just feels good to be clean and get in your bed. Eating heavy meals at night can do it to you. Refusing to take medication for sleep, and that's going to be automatic. Taking new medications, having TV, radio, computer, or light on at night, or having pain can mess up their sleep patterns. So we're going to try to make that. Yes, I'm sorry. Bed making. Make sure that it's wrinkle free. They're going to keep saying that. Wrinkle free, wrinkle free. You pull that bed tight, and you try your best to keep it as tight. And I'm telling you, that used to be a state skill. It used to be. And get all the wrinkles out. I think if I had a test, I would think if I had time, I'd get me an iron. Now you come check out my bed. Come check my bed. But in some facilities, Archibald is equivalent. You'll see the squares, but
Yes.
far as the, you know, they're pretty good at all those wrinkles not being in there already. Some will already have wrinkles in it because the way they folded them. So make sure you're pulling those out as much as you can. Occupied bed, exactly what it means is somebody in it. Unoccupied, it means ain't nobody in it. Okay, and sometimes you'll have to make up a bed with someone in it. Guess what do? You use the skill that we learned or have learned or talked about, and you turn them on their right side. And then you actually get all those covers and stick them up under them. There used to be a way you had to do it, fan it, and be all fancy, but stick all those covers up under there. Make up that side of the bed. You can roll it, stick it, however. I do both. Yeah, as long as it gets over there. Some people fan it. But we're gonna stick it as much as you can up under your patient. Make up that side of the bed, and then roll them back onto the clean. That's it. And then once you roll them back onto the clean, you'll have to take the old cover off, and then take your new that you just made up that rolled up under the patient too, and pull that across. Once you do it one time, you'll be like, oh, this is easy. I never thought it would be easy. Never in my life. But yeah, you would think it would be hard, but it's really not. And those mitered corners, I knew I'd come up with the word mitered corners, but that's how you do it. You pick it up a little bit, stuff it in, and then you fold it back down. You just have to see somebody do it one time and then practice it. But that's how they tuck the beds. And sometimes lately they have not even been tucking them like that. They're doing it for
Some of the sheets aren't long enough to do.
pretty purposes. Now they'll get their blanket and do it like that. They'll take it and it really depends on your facility. Watch how they want you to do their covers, and it'll be kind of uniform how they want them. Do they want mitered, or do they want just the cover on top that hangs? It really depends on what facility you're in. But that's showing you a little thing about how they've actually take the dirty covers, page figure 745. The dirty ones are the green. So they took the green and stuffed them up under there. Then they made that side of the bed, and also it goes up under the green. And then you take your patient, roll them back over, and that's that next picture, 746. She's rolled over all of them, and they changed the orientation. They should have kept it the same so you can get it. But and then you would pull the green, and then take that blue and spread it on out. So once you do it one time, you'll be like, oh, they made it sound confusing, but it's not. Yes, on page 200. Do not put that pillowcase up under your chin like you do at home and put on a pillowcase. You have skin or all kind of stuff possible. You know, but that's somebody's pillow. Don't be doing it. You take your clean pillowcase, actually turn it inside out, and then just wrap it around the pillow. Try that at home one time, you'll be like, oh, okay, I got that too. But you turn it, you grab it from the front, from the outside of it.
Do you have to do it that way?
Yes, or else you're gonna be too close to your own self. How else are you gonna do it?
I lay the pillow on the bed.
Oh yeah, you can do that too. Yes.
Just slide it.
Yes, there's not a state skill. Just make sure it's not up against you, and that's kind of easy. But however you done figured up your easiness, just as long as you don't have it up against you.
Like silky, like plastic almost feel.
Yeah.
And they just slide.
Oh yeah, I like the sliders. Some people you have to shake them on in. Come on, page 201, you got your closed bed and your open bed. Closed just means that this person is gone, or this person is, or they've been discharged. So they close the bed. When somebody's coming, they're gonna open the bed up. It's kind of like your turn down service. Or at night, when you're coming back to your room, they open up the bed. Same thing. Don't confuse yourself on that. Closed bed just means all the bed covers are in place, made up. Your open just means that they've folded the covers back. And they're going to fold them back because you're going to get back in the bed. They charge like $50 for that at Mel Hannah Plantation, but they'll put a little piece of fancy chocolate on your pillow. I used to work there, and I was like, I'm doing this. I need that $50. But all I did was, you fold the covers back. You have to make them real cute. I mean, not cute, but just neat. And put their little piece of chocolate on their pillowcase. A little piece of chocolate. And they paid like $50 for that. Yes. And she also had me on my hands and knees behind them sinks looking for hair. I mean, she was, and the white gloves. Literally.
Okay.
Yes. She was on there. But that's the difference in your clothes and your open beds. Discuss dressings and bandages. Sterile dressings covers open wounds or draining wounds. A nurse changes these dressings. Non-sterile dressings are applied to dry, closed wounds that may have less chance of infection. Underline that. I want y'all to know what a non-sterile dressing is and what they're applied to. They're applied to dry, closed wounds that have less chance of infection. And a CNA can change those. In other words, they've had a wound, but it's healed, but they're still covering it, just for covering's sake. Band-aids are kind of like that as well, unless they've got something that is draining or anything like that, you can't change. And that is the example of that on figure 748. That's just a simple little bandage. I don't know why they're covering it. Something happened, but it's done that way. But what they want you to know is, and I'll get a piece of, okay, we got a bandage on. This is our bandage. This is our bandage. I got my gloves on, and I'm gonna take this bandage off this patient. First, I gotta wash my hands. I'm gonna ask you how many times you gonna wash your hands to take off a bandage. So I'm gonna wash my hands, put on my gloves. Then I'm going to take this bandage off. Then I'm gonna actually put it in my gloves. That's me. Put it in my gloves. Throw that away. And that's the bandage. So after I do that, I take that off. I'm going to wash my hands because I took my gloves off. Now I gotta wash my hands. Now I'm gonna put a new bandage on. Put my new bandage on with my gloves. And then after I put the new bandage on, I'm gonna take my gloves off and I'm gonna wash my hands again. How many times did I wash my hands? That's it. They might ask you how many times you put gloves on, how many times you wash your hands, something like that. But they just want you to know that you just take this off, and when you take your gloves off, you still wash your hands right afterwards. Every time you take your gloves off, what are you gonna do? Every time. That does not go bad. Go different. Your elastic bandages, sometimes called ace bandages. A lot of times y'all won't have to put them on. Sometimes you will. Really depends on your facility you work at, because it's not a dressing per se, but sometimes it is. You can put those on things on too tight. I did that to my grandbaby the other day, and I told him to make sure check for her circulation. But I put it on too tight for her, but I thought she had broke her wrist. But she wanted a little attention on me, and I hooked her up. I got her a little splint. I got her a splint. I covered her up, and she couldn't move that arm. And I said, "Tell your mama's taking you to the doctor tomorrow, because that's all they're gonna do at the ER, split them up and get your appointment the next day." So I did that. I said, "Don't splint you up, because they ain't gonna do nothing to you, unless it was broken out or coming out. Then they'll try to do surgery, because you get infections real bad." But anyways, your elastic bandage is gonna be sometimes for circulation, sometimes for swelling. Like if they've had previous surgeries or something like that, they'll use that elastic bandage. If you had knee problems, it's good to put something on there so it won't swell. Especially ankles, wrists. You might have to do some wrapping. It really depends on where you're at. You might have to do that. But what I want you to know, and if you do have to do that, keep the area to be wrapped, clean, and dry. Apply the bandage snugly enough to control bleeding, or that's another one, if they may be bleeding, and prevent movement of dressings. And that made me remember another reason why you might use an ace bandage with a bandage. Like maybe they're allergic to latex. Me, I'm allergic to the glue on bandages, on the glue stuff. So they'll wrap me different as well. But they'll just put the gauze on me, and they'll wrap me with ace bandage because they don't want to put tape on me, or the bandages, other bandages that have tape on me on because I'm allergic to the tape on there, not latex, not allergic to latex, but it's the glue stuff.
You
It breaks me out every time. Every time. I say I'm not allergic to either one of them. It's the glue that's on it.
Yeah.
Because none paper don't bother me, you know, and I wear latex gloves, but they did irritate me. So it may be a little latex, but I'm definitely allergic to the glue. Because every time, like, you put a Band-Aid, and I don't tell them half the time, because I haven't had no anaphylactic reaction, it's gonna give me a rash. I have a rash here and a rash there from the glue on the Band-Aid. Yeah. About every time. But that's what they're saying. Some people, you're gonna have to adjust. It might be a where you're putting the dressing or the wrapping over them. And sometimes they'll do Coban. You've ever heard Coban? It's kind of like ACE, but it's just like if you're going to donate blood, they'll wrap your whole arm.
Yeah.
That's your Coban, and that's better for me too as well. It's still got a little bit stuff on it, but it has never done me like the other stuff does. But what we're going to make sure that we did not wrap it too much, or the nurse didn't wrap it too much. So we're going to make sure that last G. Check on the resident 15 minutes after. Most of the time when you're applying it, it's in a figure 8 pattern, underline that too. And you wrap it, and it's kind of like a figure 8 above and just figure 8. And that's going to give you some stability for whatever body part you're covering. So, but 15 minutes after the bandage is applied to check for signs of poor circulation. We're going to be looking for swelling, bluish, cyanotic skin, shiny, tight skin, skin that's cold to touch, sores, numbness, tingling, pain, discomfort. A lot of times you put it on too tight.